thank you to the entire team of Providence for this diabetes dialogues and inviting me here. I'll be discussing 3 case minutes pertaining to familial dyslipidemia syndromes. I hope my slides are clearly visible. I hope my slides are visible.
Yes.
Very much visible.
Okay. So the first case minute is that of a 44-year-old lady who is admitted with acute myocardial infarction. She has had history of 3 myocardial infarction 3 years prior as well, when a coronary bypass grafting was done. She has a strong family history of CAD. Her mother died of MI at age 60. Her maternal uncle and aunt also had CAD at young age. Older brother also has CAD. She is currently on atorvastatin 40 milligram and ezetimibe 10 milligram. Her LDL right now is 96 milligram per deciliter, and prior to therapy, LDL was 240 milligram per deciliter, while her triglycerides and HDL were within normal range. So we have a lady who has myocardial infarction at a younger age. She has had it previously as well. She has a strong family history of CAD, and her pre-treatment LDL was 240. And let us pay attention here that it was only the LDL which was raised, while TG and HDL were within range. So this is a typical scenario that one such scenario that should lead us to think of a familial cause. This lady had a tendon xanthoma in the Achilles tendon and a arcus ring as well. So these are the physical exam findings. Typically, tendal xanthomas are seen more commonly in familial hypercholesterolemia. So what is the diagnosis? So I have mentioned it myself. She probably has a familial hypercholesterolemia. So I'll discuss something about this category of familial dyslipidemia syndrome. Now, how should we approach such patient? Someone who has hypercholesterolemia. If it is only LDL elevated and TG is not elevated, then this is the category of primary disorders that we should think of. And these are the secondary causes. The primary ones, as here, includes familial hypercholesterolemia, familial defective ApoB100, a more common one, polygenic hypercholesterolemia, which is quite common than the other two, and a very rare one, cytosterolemia. Finally, the secondary causes, which are actually much more common than the primary causes, which include hypothyroidism, an obstructive liver disease, nephrotic syndrome, and use of thiazide diuretics. Thiazide diuretics, let's not forget, are very commonly used even for managing hypertension. And if someone has concomitant hypertriglyceridemia as well, then the secondary causes that we need to think of, the most common one is actually diabetes. Then we have hypothyroidism again. Then we have some drugs, glucocorticoids, some protease inhibitors, once again nephrotic syndrome, and some lipodystrophies. And these are the primary dyslipidemic disorders leading to concomitant elevation of cholesterol and triglyceride both. So this patient has most likely familial hypercholesterolemia. It is an autosomal codominant gene disorder, either because of an LDL receptor mutation or ApoB or PCSK9 gene mutation, leading to a decrease in the clearance of circulating LDL particles and elevation in LDL cholesterol levels. Now, familial hypercholesterolemia is not that common, but other genetic disorders, for example, polygenic hypercholesterolemia is much more common. It leads to not so striking elevation of LDL cholesterol. If you see the phenotypic spectrum here, the common polygenic hypercholesterolemia that we see usually leads to LDL elevation in the range of 130 to 190. The heterozygous variety can lead to up to 500, but there is really, striking elevation in homozygous variety of familial hypercholesterolemia. And it occurs because of the, homozygous LDL receptor mutation. Then we have heterozygous pathogenic variants, LDL receptor null, defective, PCSK9 and ApoB. And once again, it is pertinent to mention that this genetic background is modified by additional pathogenic environmental and dietary modifiers as well, and lead to concomitant increase in CAD risk. CAD risk increases as LDL goes up. What is the estimate prevalence of familial hypercholesterolemia? Well, it is not all that common. It is probably 1 in 5,000 individuals, but the polygenic variant is much more common than that. Now, there is 3 to 13-fold higher risk of CVD in these patients, and untreated males with FH have 50% risk of MI by 50 years of age, whereas untreated females have a 30% chance by age 60. Other cardiovascular risk factors such as male gender, BMI, diabetes, hypertension, smoking, they all modulate the risk of ASCVD. And here we see a pictorial representation of the cumulative life years of LDL exposure and age in years. We see the homozygous FH variants leads to very high risk of CAD early on, whereas the heterozygous variations are not that dangerous. They also lead to CAD risk, but not that much as homozygous. And we can modify this risk by high-dose statin therapy. This is one such criteria that falling short of genetic diagnosis of FH can help us diagnose. Obviously, genetic is also included here. Total cholesterol, this is based on total, I'm not going to detail completely, based on total cholesterol, tendon xanthoma, DNA-based evidence, family history, and family history of raised cholesterol and MI both. So definite of some of these and possible by others. So this is one such criteria. The other one is a Dutch lipid clinical network diagnostic criteria, which is a point-based system. Once again, gives points based upon different attributes and LDL concentrations and the presence of tendon xanthomas and acrus cornealis. Definite by more than 8 points and unlikely by 0 to 2 points, and probable and possible in between them. So this is one such criteria. Now, why are these clinical criteria proposed? Because there are problems diagnosing FH. There is widespread statin use, which makes a definitive diagnosis of FH using clinical criteria difficult, because lipid lowering therapy can abort the development of xanthomas and corneal arcus. These are rarely seen these days because of the lipid lowering therapy only. Now, lipid lowering therapy also reduces or delays the occurrence of ASCVD events, and often very difficult to know the before treatment LDL cholesterol levels. And at the same time, genetic testing is not easily available, and it is not always positive either. So that is why the use of clinical criteria. Now, we can have cascade screening. By cascade screening is when we diagnose a patient with FH, we should check for degree relatives as well. If genetic testing is positive in the index case, then ideal to screen with the genetic testing only, because we know which gene is mutated. If genetic testing was not done or did not reveal the specific mutation, then we have to screen with lipid panel. So cascade screening is one way to go. Now, what to do here? Patient is already on statin and ezetimibe. So the next good option here would be to add a PCSK9 inhibitor. And this is what the guidelines also mention, the ACC guidelines in patient with severe primary hypercholesterolemia, wherein their LDL elevation is beyond 190 milligram per deciliter. Without calculating a 10-year ASCVD risk, we have to begin high intensity statin therapy. And in very high ASCVD, use a LDL cholesterol threshold of 70 to consider addition of non-statin. So here that is indicated because LDL cholesterol was still 96 milligram per deciliter. So that was first case of isolated elevation of LDL cholesterol, strong family history of premature CAD. These are the differential diagnosis of primary and secondary causes, and this is how we treat. Now, moving on to the second case, a 22-year-old male referred with a history of 2 episodes of pancreatitis, admission triglycerides of 3000 milligram per deciliter. He's thin, he exercises regularly, he drinks alcohol moderately and sporadically. He's not on medications that raise triglyceride level, and he does not have diabetes, renal, liver, or any autoimmune disease. So primary problem here is isolated hypertriglyceridemia. So what all secondary and primary diagnosis we should consider while seeing such a history? Pancreatitis is directly attributed to the very high triglyceride level here. The exact etiology is not known. There are only postulated mechanisms, but pancreatitis is here because of hypertriglyceridemia only. Now, most common secondary causes include diabetes and hypothyroidism once again. If we consume high carb diets, once again, if we have binge of alcohol intake and consume high carb or high fat diet, once again, secondary causes, these are the secondary causes of hypertriglyceridemia. The primary ones are lipoprotein lipase deficiency. Now, lipoprotein lipase is the enzyme that actually metabolizes chylomicrons that are released from the intestine postprandially, and hence makes available to the liver for further processing. ApoC2, once again, is a cofactor for this enzyme, and hence potentiates this only pathway. Then we have familial hypertriglyceridemia. So these are the primary, less common disorders, but secondary are most common. Now, this DD is for isolated hypertriglyceridemia, and that is what we are discussing now. The other concomitant causes of chylomicronemia, which include binge alcohol intake, uncontrolled diabetes, drugs like protease inhibitors, corticosteroids, retinoids, some women particularly taking high doses of vitamin A, they can have hypertriglyceridemia. Pregnancy and autoimmunity as well leads to chylomicronemia. There are case reports of GH1, BP1 cofactor for this lipoprotein lipase, tethering it to the endothelium. That autoimmunity to that molecule also leads to chylomicronemia. Now, inherited or familial chylomicronemia syndrome as a result of homozygosity or double heterozygosity in genes that control TG metabolism is very rare. So this primary dyslipidemia causing hyperchylomicronemia is rare. However, acquired issues are much more common once again. They are as frequent as 1 in 200, and they can represent a complication of uncontrolled. All of us see patients of uncontrolled diabetes in our clinics, which have high TG levels or excess binge alcohol consumption. So all of us can develop hyperchylomicronemia. We need to just saturate our LPL, lipoprotein lipases, and then consume a high fat diet. For example, if we take maybe 80 or 100 grams of fat after taking a binge of alcohol, we will also have hyperchylomicronemia. So why TGs are elevated as much as 5,000 milligram per deciliter in these patients? So is it because of blocked plasma clearance of the hepatic or the GI or all TGs? It is because of blocked plasma clearance of all triglycerides, both from the liver as well as from the intestine. Because lipoprotein lipase is the one responsible for metabolizing this. And if we see the metabolism here, chylomicrons are large lipid particles. They carry triglycerides from the GI, from the intestine towards the liver and metabolized by lipoprotein lipase, and hence further processed in the liver. And as we see here, the same thing, chylomicron from the intestines, metabolized from lipoprotein lipase in the capillary endothelium, and they once again the remnant particles are cleared by the liver. And so this is in nutshell the metabolism. I'll not go into the detail. So treatment here would be full dose phenobarbital and omega-3 fatty acids. And whenever the TGs go still beyond 1000, fasting under medical monitoring, medical supervision can be done for 24 hours or 48 hours if the need be. It is difficult, but so as to avoid another episode of pancreatitis, that sometimes needs to be resorted to. So I'll very quickly go through the third case as well. This case is that of a 52-year-old lady who has coronary artery disease and a strong family history of premature CAD once again, just like the first case. No other CHG risk factors. Her lipid panel suggests triglyceride of 100, HDL of 50, and LDL of 130. So nothing much wrong here. She was treated with atorvastatin 40 milligrams, which brought down her lipid LDL by only 23%. So what is the reason for relative resistance to atorvastatin therapy here? What is the disorder? So that's what the question is. What is the likely cause of modest decrease in LDL with statin therapy in the case? Well, the answer here is high lipoprotein A levels. Lipoprotein are LDL particles which are through a disulfide bond linked to ApoA. And why this is important? They are produced by the liver, but clearance pathways are not very clear. And they are regulated primarily by the rate of production. And production is greater in individuals with small isoforms, leading to high serum level because they are not very well cleared. 90% of variation in their level is genetically determined, and the clearance is not regulated by LDL receptor, and therefore statins and ezetimibe both do not lower lipoprotein A levels. And how much of lipoprotein A is there? Contribution of lipoprotein A to the LDL cholesterol is usually 0.3 times the 0.3 times the LDL. For example, if the patient has 150 milligram per deciliter of LDL, we can estimate that 45 is contributed by lipoprotein A. So 0.3 times, 30% is lipoprotein A, and some individuals have more who are genetically predisposed to that. And yes, lipoprotein A do increase the risk of CVD, as we see in this case scenario also. There is history of premature CAD, there is strong family history of CAD as well. So with elevating levels of lipoprotein A, the risk ratio of CAD also, non-fatal MI and coronary death goes up. So the Mendelian randomization studies and genome-wide association studies strongly suggest that elevated lipoprotein A is causal and not just a marker of ASCVD. There are potential mechanisms. One, uptake of lipoprotein A by macrophages in the arterial wall and hence potentiating atherogenesis. Increased oxidized phospholipids carried on LPA having pro-oxidative and pro-inflammatory effects, and because lipoprotein A also inhibits the fibrinolytic system. So these are the potential mechanisms. Now, this slide is very important. I'll just give a couple of minutes here. When to suspect this and when to measure lipoprotein A. Patients with unexplained premature CHD, when we're not sure what is going on, and the patient has premature CAD. Patient with, once again, with a strong family history of premature CAD. Patients with a family history of elevated lipoprotein A levels, which is cascade screening, as we discussed for familial hypercholesterolemia as well. Patients with resistance to LDL cholesterol lowering with statins, just the way we saw in this particular case. Patients with rapid unexplained progression of atherosclerosis. Patients with familial hypercholesterolemia, with early aortic valvular stenosis when the cause is uncertain. Then finally, some experts recommend, everyone has, but that is not, universal guideline. So these are the recommendations. These are the potential times when we should measure lipoprotein A. Now, suppose we measure and we do find it elevated, what to do? What can we do? Well, there are issues here. Diet and exercise does not have any effect on circulating lipoprotein A levels. Statins only slightly have any effect, if at all they increase it. Ezetimibe, once again, no effect. Fibrates, no effect. Niacin, there is a very slight reduction. PCSK inhibitors also decrease, but they are very, very costly. Estrogens, we cannot just prescribe estrogen to anyone with this, lipoprotein A elevation, but they do decrease it by 20 to 30%. So there are mild decrease with niacin, PCSK9 inhibitors, and the drugs that are more commonly used, statins, ezetimibe, and fibrates, do not have any effect on lipoprotein A levels. So lipoprotein apheresis, well, that is not easily available and maybe limited to very few patients who are very high risk. So in a nutshell, for lipoprotein A, we have to suspect when we do not have an explanation why statin is not working. Obviously, compliance first we have to see in the Indian scenario at least, and then we have to measure lipoprotein A levels. A very, concomitant risk factor reduction has to be put into place here, because these patients are at high risk of CAD. Not just reduction of lipoprotein A levels, but concomitant reduction in other risk factors as well: smoking, blood pressure control, promoting physical activity, reducing weight. So all these things have to be reinforced very tightly, because anyway, lipoprotein A levels cannot be reduced to a great extent, but we can bring down other risk factors and hence bring down the CAD risk. So I think I have finished in time. That was from my side.
Yes.
I think I have finished in time.
Okay.